Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, my name is Dr. Diego Maselli. I'm the Chief of Pulmonary Diseases and Critical Care at UT Health in San Antonio, where I'm also a professor of medicine. Welcome to our program today. Today, the title of our program is Right Care, Right Time, Clinical Pathways for Identifying and Referring Moderate to Severe Asthma. Today, I'm very fortunate to be joined by two of my colleagues. I would like to introduce Dr. Marina Resnick and Dr. Chuck Vega. Guys, do you want to introduce yourselves?
Yes, sure. Hello, good afternoon. My name is Marina Resnick. I'm professor of pediatrics at Albert Einstein College of Medicine and vice chair for clinical and community-based research in the Department of Pediatrics at the Children's Hospital of Montefiore. I'm a primary care pediatrician and I'm an NIH-funded researcher whose research focuses on intervention development and evaluation of in the community clinic and school-based settings for children with asthma.
My name is Chuck Vega. I'm a clinical professor of family medicine here at the University of California, Irvine. I'm also an assistant dean in the School of Medicine. Just really excited to talk about this important subject. I too work in a federally qualified health center, safety net clinic in the middle here of Orange County.
We're so happy that you're joining us today. Thank you so much both for being with us today. So, today we're going to be discussing some of the management of our patients with moderate to severe asthma. Our conversation is going to focus on the use of oral corticosteroids and some of the referral patterns and some of the current practices that are out there in our community. We have a great faculty, so today we're going to have a great discussion. I think I'll start by mentioning that really in our current practice, day and age, I think we have some suggestions from the practice guidelines of how to treat our patients with asthma, particularly with the use of oral corticosteroids. Despite that, I think there's still a evidence gap, or there's still some information that needs to be disseminated about the use, or as I would say, overuse of oral corticosteroids for our patients with both moderate and severe asthma. I think our community and our practice continues to have an over reliance on oral corticosteroids, and patients are getting exposed to these steroids. As we are well aware, our patients with asthma get exposed to these steroids during exacerbations, but also may get exposed to this on a day-to-day basis. And we're familiar with some of the side effects, but I think it's important to mention that there are both short term and long-term side effects that occur with patients after exposure to these steroids. Short term side effects will include things like fluid retention, problems with sleep, problems with increased weight, increased appetite, and long-term side effects. We're also familiar with diabetes, osteoporosis, weight gain on the long run. But it's interesting that over the past several years, there's emergent data that some side effects occur that maybe we're not as familiar with or not as aware of, which includes increased risk of cardiovascular disease, such as stroke and heart attack, but also things like anxiety and increased risk of depression. So, of course, these are things that we want to prevent in our patients, and we want to try to prevent these side effects from happening because some of these effects, as you may imagine, are irreversible. So, a lot of focus on this area of the care of our patients with both moderate and severe asthma and asthma in general. Why are we using so much steroids, one would ask, right? What's the reason behind this? Well, I think as we have experienced in our practices, when a patient gets steroids, they feel better. They feel better relatively quickly. And some people would argue that this is a quick fix, right? Quick fix, in and out, you get the steroids, and it provides this, I would say, false sense of reassurance. So there's a lot of these things that come into play. In addition, I think some of our patients feel reassured that their asthma may be controlled because we have this quick fix and are not familiar with the fact that these side effects may occur. When we talk of our patients, we ask them, Have you been using prednisone? Have you received injections, dexamethasone?" And often the patients may not necessarily even remember these things from happening or may not keep good track of these things. And I think importantly, some of our patients may not necessarily know that the side effects exist. They may tie some things like weight gain or diabetes, but other things that I mentioned before, like anxiety and depression, may not be necessarily aware for them. So I think this is some of the things that we'll be discussing today and some of the strategies to try to educate our patients, educate our providers, our colleagues, and what can we do to try to prevent this from happening. So I think before we move on into the discussion, at this point, we would like to hear from a patient about their experience living with uncontrolled asthma and how oral corticosteroid use has had a significant impact on them.
I'm Brenda Young. I am 59 years old and I have severe asthma. So, living with severe asthma does affect my daily life, such as taking showers are hard every day. They take too much energy and too much breath. And I do have to plan my days out or my weeks. I can't be overscheduled or I will not be able to make all those. So it's always a thought process. It's always on my mind what to do. But two major examples are my one daughter's high school graduation. I was unable to attend. I had a really bad time and I could not even walk without oxygen even. So I was unable, their graduations outside. So that was a big disappointment. And then another time was my youngest daughter's college graduation. I could not attend. So initially I was on steroids, I would say a couple years, and I was not informed of all the side effects. So I thought it was just part of it. But then, as actually I lowered my steroids, I continued to have really bad side effects. And then, if I had a flare and had to go in the hospital, which was frequently, I would have more steroids. So it is hard to say, but within a year of taking oral steroids, I could see side effects. Some of those side effects are weight gain, moon face, bone density, um, mood, anxiety. My eyes have cataracts already, and I shouldn't at this age. Now I am so on top of it, the side effects. If I see or feel something, sometimes I can't do anything about it, but at least the awareness is there.
We're now going to discuss two cases. We have an adult patient and also a pediatric patient. And as we discuss these cases, I want you to think about how can these cases may impact uh, the way we practice, the way we approach our patients, and perhaps if an earlier intervention could have been beneficial.
Yeah, I'll go first. That's a great setup. Jaime is 34 years old and was diagnosed with asthma around age 7 years of age in Mexico. And he's been having difficulty controlling his asthma for many years. One of the reasons is he has irregular care at all and care for his asthma with intermittent medications running out, having to use urgent care, no, lacking a medical home. I said has been hospitalized 4 times in his lifetime at least. The last time he was hospitalized with asthma was 2 years ago. Now he is on an effective treatment. He's taking a maintenance and reliever inhaler with budesonide with formoterol at a high dose, 160 slash 4.5 micrograms. It's two inhalations twice daily. So I put a pin in that he's taking a pretty high dose and should be very effective ICS LABA combination. Yet he is still using his albuterol 4 times per week. So I find that even my patients, when they could be using their controller as their rescue, they continue to use albuterol too, which was provided by another clinician somewhere. For good reason because the patient's having frequent asthma attacks. Now, the patient had seen you 2 months ago. You referred to pulmonary medicine at that time because this is severe asthma. I want to have this is not a common patient for me with asthma where I feel like I have good control. That exacerbation history, every thing points to we need to consider stepping up care. The fact that he's not controlled on a high dose ICS LABA is unusual. But guess what? I don't know what happened to his referral, and he doesn't remember being referred to pulmonary medicine. So we don't know. We have to track that down. It's with his managed care Medicaid insurance. I do give him an asthma controlled test score, and that's 13, which indicates very poorly controlled asthma. I want to check the technique of how is he using his inhalers? Want him to show me that, especially since he's relatively new in my practice. But he didn't bring his inhalers. I'm busy. I don't have samples lying around necessarily. So we have to cross that one off the list of things we can do. And his exam is notable for some wheeze, no rhonchi, but he has diffuse wheeze across his pulmonary fields. And so talking to him a little bit more about, gosh, it seems like your asthma is not well controlled. How is it affecting you? He explains that he's really scared about losing his job in construction. He really depends on that and he's living paycheck to paycheck. He tells you some of the guys will help him out, but he's falling behind at work, and yet he acknowledges it's the work that makes him sick. It's a dusty, dirty environment, and he knows that when he's not working on the weekends, he feels better. So overall, I think that there's a few things that I want to work on here, but I guess I'll pitch it back to Marina and Diego. Anything stand out, or do you have questions about Jaime's case?
Yes, definitely. It seems like there's some gaps in his insurance. Maybe it's because he didn't have standing job, or this is a new job for him, so that he had lapses in medication. And then, with exposure to dust at his work, that is seems like a major trigger, and he identifies that as such. So I wonder if some sort of measure of like wearing a mask, perhaps, is something that to consider, that may help him in terms of, the job. Like it seems like he needs this job. So, or looking for another job. I don't know how easy that would be. But those are the two things that kind of come in mind.
When you hear this story of someone not responding to high dose inhaled corticosteroids and the risk factors that you mentioned, using a lot of albuterol, being exposed constantly to the environment, yeah, it puts him at a high risk for future exacerbations. So this is someone that we have to watch carefully.
Yeah, for sure. And I totally agree. Like I feel like in primary care, our job is to keep that ground game going. It's not glamorous, but thinking about things like adherence, their technique with their inhalers, what triggers they have and trigger avoidance and comorbidities. Does he have obesity, a GERD that's uncontrolled? There's a number of conditions that can contribute and make asthma worse. Um, and yeah, absolutely. A simple thing like a mask can actually go a long, long way in terms of cutting back on symptoms and risk of exacerbation. I think it's very important to get that longitudinal history so we have some idea of his exacerbation history, but we don't know about his exposure to corticosteroids. So that would be worthwhile to know. Beyond those hospitalizations, you have to be pretty sick in these times to be hospitalized for asthma. How often is he going to urgent care, and how often is he received oral corticosteroids? Because that may, he has four hospitalizations. He might have 20 visits to an urgent care or an outside provider who provide him with oral corticosteroids. So I think that that's one thing that's really important too in terms of his history, because I like to get both ideas. How often do you use any kind of healthcare facility on an urgent basis, and then what happens there when you do go in?
Yeah, these are fantastic points to consider. If a patient has these exacerbations, as we mentioned before, this means that they're going to have exposure to oral corticosteroids, and of course, this will increase the risk for poor outcomes and adverse events. Chuck, for a patient like this, how do you communicate the risks of oral corticosteroids to your patients? What messages do you give?
I think if there's one key takeaway from my perspective to this great discussion today is that just really stop, pause, and think about: do I need to use OCS here in this case in front of me, and how can I prevent this from happening again? Because every even short bursts of corticosteroids, which is what we frequently use, are associated with an increased risk in observational research of things like sepsis and fracture, and these are tied usually to the time around the month after the patient takes OCS. So the number needed to harm is about 1 in 1,000, but these are pretty big outcomes, right? When we think about fracture or sepsis, and of course your diabetes is going to become worse. There is the weight gain, etc. So I tailor it more to what the patient may be concerned about, and maybe start with just asking what they know about the potential side effects of oral corticosteroids, and do they have any special concerns? Oftentimes, then they'll ask me, well, what should I be concerned about? And I'll give them a brief description of some of those side effects and why we really want to avoid it, as well as the fact that we want to keep the just keep bringing it back to control. I want to control this illness so you don't have to be seen urgently, and ever, or at least as little as possible.
Yeah, these are very good points, Chuck. Sometimes when I talk to my patients, I also add the fact that some of these side effects may be irreversible, and sometimes like maybe that gets the point across a little bit stronger. But I think talking about them, finding out what they know, is very important as as a first step, and then kind of seeing what the conversation looks like with them. So you did mention the oral steroids, and we talk about the side effects of this. Now, when we talk about high dose inhaled corticosteroids, what's your perception about the efficacy of these, and do they have side effects? What are your ideas about this?
So still, we are in a big time danger zone. Even if Jaime doesn't have exacerbations on that high dose inhaled corticosteroid, he's still going to some of that steroid, and it's different for different steroids, and but some of it will certainly be absorbed, into the bloodstream and cause some of those same side effects. So up to 30% of the dose may be absorbed and can be found systemically, leading to some of the harms associated with chronic steroid use. So yeah, I still take that really seriously, and I think that's why I did the and hence the pulmonary medicine evaluation at the last appointment was really to start opening the door to biologic therapy. If he really needs that much medication to control his asthma, and particularly when he's using it and still not controlled, that's a clear indication we need to step him up to a different level of care. And that's why the referral was made.
Yes, these are great points. I think when you examine the literature, the shift from medium dose to high dose inhaled corticosteroids sometimes may help patients, but that improvement is not consistent across the board, if you look at the evidence. So I agree with you that at some point when the patients continue to exacerbate, you're switching to high dose inhaled corticosteroids, perhaps considering a step up therapy, for example, to a biologic or something else. It is very reasonable. I thought this case was fantastic. It illustrates several very important points that we see on a day-to-day basis with our patients with asthma. I think now we're gonna switch gears a little bit. We're gonna now turn to Marina, and she's gonna talk to us a pediatric case in this time.
So this patient is new to the practice, so think about that. This is Samantha. She's a 7-year-old girl diagnosed with asthma at age 4 years. Her mother and two siblings also have asthma. Samantha missed her two follow up appointments for asthma since mom could not take time from work. Mom reports that Samantha missed 10 days of school this past school year because of her asthma. She has nighttime cough, and mom woke up at least 5 nights over the past month to attend to her. She also has daytime symptoms more than 2 days a week. Um, when asked how she's doing at school during her gym, Samantha said that she has been sitting out during gym class and during recess because she can't keep up with her peers. In terms of her healthcare utilization, mom reports 2 emergency department visits and 3 urgent care visits in the last year. And mom couldn't remember, but she thought that 2 or 3 of these visits, the oral corticosteroids were prescribed, and the last one was 1 month ago. Mom reports that Samantha has gained weight over the last year, and she has some concerns about her behavior at school and also at home. The teachers mentioned that she has some angry outbursts, and mom also noticing that she's more hyperactive. Her current treatment includes fluticasone 110 micrograms, 2 puffs twice a day. Albuterol is needed, and mom says that she uses albuterol 4 to 5 times a week. Oftentimes, it's either pre or post exercise. And then she also takes cetirizine for her allergies. When asked what type of allergies she has, mom did not know. It seems like she's having symptoms year round, and she's never seen an allergist. Um, Families seem to say that these kind of symptoms are normal besides those exacerbations. And between the flare ups, she feels totally fine. And mom says that Samantha is feeling better now than before. On exam, her lungs are clear to auscultation bilaterally. And another notable finding is her body mass index for age is at 87th percentile. So when hearing this case, I have more questions. Um, Generally, I would want to know about adherence and just asking out of a typical week on how many days out of the week did Samantha take her controller medication. And then because she's 7, I want to know who oversees her medication. A lot of times in my practice, even 7-year-olds are taking over and administering the medications without parents seeing it or having some sort of oversight or administering the medication. Then I want to know about, do they have routine set for taking a medication, and especially if they're reporting that, let's say, they're not adherent. And then we'll talk about, you brushing your teeth twice a day, so just remember to take the medication before you brush your teeth, and then you rinse your mouth. Um, I also want to know about triggers, like why she had all these exacerbations. Do they know what triggered it? Is it like an upper respiratory infection? Could it be that they have exposure to furry pets? Do they have a cat at home or a grandparent home? Do they have pests at home? Do they have mold? Do they have smokers? We talk about house dust mites. I often, even if I don't know if they're allergic to it, I just ask them, do you have hypoallergenic mattress and pillow covers? And then for children, it's also important to know, do they sleep with stuffed animals? A lot of them have in their bed, and not knowing that they could be collecting dust. And then we'll talk ways. If they identify what are the triggers, we'll talk about how do you avoid the triggers. Comorbid conditions, certainly to have, she falls into the overweight category. So we'll want to talk about healthy diets and physical activity, although she's having exercise induced symptoms. So it's important to talk about use of albuterol pre-exercise or warming up before exercise. Again, a lot of patients may not even know that that's what they should be doing. And then allergies, it seems like she has not seen an allergist before. Mom doesn't know what she's allergic to. I would want to know about their inhaler technique. A lot of children I see, they don't even use a spacer. They don't have a spacer or valved holding chamber. So you want to know, do they have one? Do they use it with the mask or a mouthpiece and go over the steps? And then I like to ask them like a teach back using teach back method, and they'll tell me what you just hear. Can you repeat the steps? Because education here is important, and just telling them like the spacer or valve holding chamber is important for them to have so that the medication gets delivered to the lungs. Um, what are your thoughts on sort of these initial sort of assessments and questions?
Yes, no, I think that's it's a very complete evaluation. Of course, I'm an adult pulmonologist, right? So we don't have a lot of the same similar questions, but it's very interesting that you touch on so much similar in the areas of exposures and things that are very important: compliance, education, inhaler technique, comorbid conditions. Just like in Chuck's patient, these are important things as well. So definitely it's the same patient population. Asthmatics can be young and can be old, but they have the same exposure to the environment, to triggers, viral infections, and they sometimes face the same challenges, right? Seeing specialists becomes difficult. Seeing, having exposure to oral steroids becomes frequent, and in the end, they face the same difficulties. And so I wanted to ask you about this specifically. About, you mentioned an allergist, in an allergist potentially. When you're thinking about referring a patient for a specialist, how do you approach that conversation with the parents and with your patients?
Yeah, so in this case, I would say Samantha's asthma is not well controlled given the history that you just told me. That she's been using emergency room and urgent care too frequently and receiving too many doses of the oral corticosteroids. Um, and in terms of the history of allergies, we don't even know what she's maybe allergic to. So I would like to refer Samantha to be seen in an asthma center where she'll see an allergist and also pulmonologist. And then allergist will do an allergy testing where we can identify what she's allergic to so that we can avoid or you can take steps to avoid these triggers and manage these triggers. And then for pulmonologists, they can do the lung function test. And based on these results, the history and response to therapy, and the results from allergy testing, there may be another medication that need to be added to manage her asthma better. And and I'm thinking of biologic at this point. I also, just to add, in terms of her medical management, uh, the point where I would consider referral is, we went over the adherence. She's adherent to her medications. She's not on a optimal treatment. I would want to step up and prescribe ICS for Formoterol, for example, in this case. And while I'm doing that, I would also refer her because I know that referral may take some time for them to get an appointment. But she's already done on proper medicine, and then we can reassess. Within 2 to 3 weeks, is this working? Or if she's not seeing me and she's actually got an appointment with allergist or pulmonologist, they can follow up on that. So at least we're not just waiting. And let's say has been taking her medication as prescribed. She has, we went over technique, etc. So at least we have this process moving forward.
Yes, for me, for example, when I'm trying to refer patients, I often collaborate with ENT, with allergy. Sometimes it takes a while to get these patients seen. And so we try to do as much as we can, but always do kind of multiple interventions as much as we can to try to help our patients and expedite the process. I have like speed dial some of these specialists to try to get them as soon as possible, but it is a difficulty, and hopefully our medical systems will improve so that we can refer these patients. I think the overarching message is, once we identify a patient that's at risk or a high risk patient, is starting the referral process is likely what needs to happen. And in the meantime, we try to do our best that we can with our teams, and then try to help our patients the best way we are possible to do. So once the patient has been referred to a clinic, for example, a pulmonary clinic or a allergy clinic, what's the next step? What happens to these patients? So I think at this point, most specialists will try to understand what type of asthmatic we are dealing with. In this case, we're trying to do some phenotyping to try to understand what are the underlying inflammatory pathways that might be activated. So here we focus a lot on type 2 inflammation and some of the markers of type 2 inflammation. And the classical workup for these patients includes blood eosinophils. We can do this relatively easy and inexpensively with a CBC and a differential. We typically obtain an IgE level. We do some allergy testing we can do in vitro or in vivo if you're an allergist. We also are measuring more and more nowadays exhaled nitric oxide, which is phenol, and we do that relatively easy at the point of care at the bedside with the patient. And of course, Marina mentioned, right, PFTs. We often do pulmonary function testing, spirometry. Sometimes we are doing plethysmography in some of our patients, and potentially some additional studies, which may include chest X-rays and sometimes CT. PFTs and imaging sometimes are helpful to confirm the diagnosis of asthma, to establish the severity of the degree of obstruction, and that might be helpful so that we can kind of formulate a plan. Often, as you know, there's a lot of asthma mimicking diagnosis that we are encountering, and patients that are not responding to standard therapies, sometimes we face with different things, and the differential diagnosis is long, but it's important to just be thorough with these referrals. And why is
Diego,
this
if I
important?
can interject for a second, this is to help
Yes,
make
Chuck.
your care a ton more efficient. Everybody with asthma and COPD, for that matter, should have a CBC with diff on file, so we have some idea. The blood eosinophils correlate fairly well with the bronchial eosinophils that we're interested in, and if they haven't, especially if they haven't had pulmonary function testing in a while, say years, which is often the case, getting a new round of just basic spirometry with a pheno could that way you're able to see all those results and work to the best of your abilities. You don't have to wait, on your end for the patient to complete those tests. And, usually that's another couple months before they see you again.
Yeah, these are very important points. I think a lot of patients do get that CBC with a differential, so we have that data already available. Now we're doing a little bit of more of a trending. So I would, if a patient's coming to see me, I'm already looking at what was your eosinophil count, let's say a year ago, 2 years ago, and even beyond, and getting a new level, but at the same time comparing it to a trend. And I think Marina in pediatrics too, I think you do the same, kind of like looking at trends, what the biomarkers may show, correct?
Yes, correct.
So, because why are we needing to do this and what's the importance of doing the phenotyping? Well, we have now medications that are approved for the treatment of severe to moderate to severe asthma. And in fact, we have now seven different biologics that have been shown to be efficacious in not only reducing exacerbations, but also they can decrease the need for systemic corticosteroids. And even in those patients that use steroids on a day to day basis, those that are very severe, those severe asthmatics. Additionally, and very importantly, randomized control studies have also shown that these biologics are safe. And in fact, open label extension studies and real world studies have also shown that these medications, fortunately, are safe. Now, you did bring, both you, Marina, and Chuck mentioned the importance of exacerbations, right? And in the randomized control studies, these studies showed that exacerbations are reduced when the patients are on biologics. And less exacerbations equals less steroids. So they have that oral corticosteroid disease sparing exposure when you use these medications on a regular basis. Beyond exacerbations, we now understand that these biologics may also potentially have some disease modifying qualities. What do I mean by that? Well, potentially they may preserve lung function. They may potentially prevent airway remodeling, which is one of the fears that we have with sustained and uncontrolled inflammation in the airways. And recent studies, in fact, have shown that there's some evidence that some of these biologics may potentially at least partially reverse some of the airway remodeling that these patients have. So this is an exciting area. Not only do the patients get less exposure to steroids, less exacerbations, improvement in the lung function, and potentially improvements in their quality of life, and potentially some reversal of their underlying disease. And as we continue to strive to control these patients, to improve these patients, then over the past several years now, maybe 4 to 5 years, there's been a lot of conversation on the topic of asthma remission, a topic that's been, labeled remission, kind of borrowed from maybe rheumatology, maybe oncology, where our patients have their asthma completely under control. What do I mean by that? What does asthma under complete control look like? Well, this will be a patient that has had no exacerbations, that has good, stable lung function, that uses rescue therapy very infrequently, and that this has been sustained for at least for 12 months. And, in some of our severe asthmatics or moderate asthmatics, this goal may be aspirational, but I think we are in an age where we can treat our patients effectively. We can have selective therapies. We talked today about education, prevention, comorbid conditions, inhaler technique, but now we also have tools that target very selectively these pathways that can potentially prevent future progression of the disease and improve the outcomes in our patients with moderate to severe asthma. Well, Chuck and Marina, as we conclude, I would like to thank you so much for presenting those very interesting cases. And before I let you go, I would like to ask you one last question. And when you are speaking to your patients and talking to them about their asthma, how do you educate them on their importance of asthma control? And I'll start with Marina.
Yeah, great question. So I like to really talk about not just episodic improvement after exacerbation, but a long-term control. Talking to them and educating them about the risks of the oral corticosteroid, and the goal, want to make sure that our goal is the same of having no exacerbations requiring oral corticosteroids, and then importance of regular follow-up, which is uh, assessing their asthma control, review those set goals, review their technique, talk about, any other triggers, effects of their therapy, and then making sure that, if they need to be, referred to subspecialists, that appointment actually took place, and then we can improve their overall asthma outcomes.
Thank you so much for those thoughts. Chuck?
Yeah, I can't add much more to that. That was awesome. But I would just say, just emphasizing to patients that we are in this together. We're here to help you, and you're going to make the decisions. But I'm here to guide you towards those right decisions, because it is about improving your function and your overall well-being over time, and making a difference in those long-term outcomes of asthma. Every exacerbation counts. Every use of OCS counts against you. So really, that's what we want to avoid together to get you those functional goals.
Well, I would like to thank Drs. Chuck Vega and Dr. Marina Resnick for that fantastic discussion. Thank you so much for presenting those very interesting cases, and of course, for your great insights on the management of our patients with severe asthma, moderate asthma in the pediatric setting and in the adult setting. Thank you so much for being with us today.
Thank you
Thank
so
you.
much. Thank you.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Once again, thank you so much for joining us.